Hello, my name's Jules. Welcome to The Secret Mind. Hopefully the sound will be a bit of an improvement today. I've been struggling with it. This is another episode of my police memoir, Unpunished, because police custody is not a place of punishment. It's a place of assessment, a holding area. So unpunished, as in no good deed goes. This is, I think, a connection, an extension of the last one I did. It might be, it's a different way of looking at it, or an extension. It's a separate piece. Here we go. She was unaccompanied. Here we go again. She was accompanied by the police officer and the voluntary resident of a mental health unit. It was half an hour past my shift, and after 12 hours, I was ready to go home. The duty doctor for the shift that now started in 11.5 hours' time had phoned in sick, so I had inherited that shift too. Thinking he clearly needed major surgery, I was happy to help, kind of. But when he telephoned me later and it transpired that he was suffering from a cold, it took all my personal communication skills to feign sympathy. I was already facing doing 72 hours in 9 days and reminded myself that my junior doctor years were supposed to be well behind me and that my crow's feet were ready for their pedicure. Still, a hero is a hero, and you can't keep a good man down. There was a reason why in providing a service, no FME, forensic medical examiner, shift had gone uncovered in living memory. And that was simply because as a group of doctors, we covered it. The service did not waste money on outsourcing companies or managers incapable of doing a clinical shift. We did that tiny aspect of the job ourselves and put all our resources into the role. Does anybody remember that old aphorism? Don't ask anybody to do something you can't do yourself. It doesn't really work with middle management, does it? Because they're not, capable. It's all, remember to delegate. Remember the 80-20 rule. A litany of poorly understood business speakery and quick fixes endlessly regurgitated and sold as truth. It's rife. But what might work in McDonald's has consequences in frontline medical decision-making. At some point, and it may be difficult for these people to understand, somebody has to step up and take responsibility. Somebody has to make a decision that is not deferred. Somebody has to be the meeting and not just put one in the diary. Minor irritations aside, there was a job to be done, and standing in front of me was a highly unusual situation. For the first time in 5 years of doing the job, the detainee was accompanied by a staff member from a mental health unit in my custody suite. This was the stuff of legend. My heart soared into an epic world of imagery and possibility as I peered at the mythical creature standing tall in front of me. Was that a fleece of gold? The head of a rampant lioness? A hairdo of vipers? I blinked my eyes. The mists parted, and now in front of me was a fully fed junior nurse wearing a cocky, unhelpful smirk. I was home. To actually have a secondary source of useful information was a rare privilege, so my hopes were still stratospherically high. The brief, the senior nurse of the psychiatric hospital had had her patient removed by the police. So was she already sectioned? In any sensible world, the priority would have been to have provided some information. But the true priority had clearly been to deliver on a promised punishment and call the van to take her nemesis away. You can almost imagine the staff lining up to tap the police van as it pulled out of the hospital driveway, as everybody joined in with a chorus of, "We told you what would happen." Then go and sit down for a well-earned cuppa. The uncharitable might question the continuity of care, if not the duty of care. The problem had gone away, or rather, it had been displaced. But it doesn't go nowhere. It comes here. And who would imagine a qualified doctor here to greet her? Today, then, it comes to me as a minor player, and to the equally confused police, the major players. The problem has been plucked from a specialist facility in the heart of a huge, sprawling county, a specialty with hundreds of doctors and nurses and countless mental health workers. And today, they have requested the removal of their patient from their eye line and immediate environment. To mine. Not nowhere, but here. Police custody. The police are rightly edgy and apprehensive about these situations. It's easy to forget with their sharp uniforms and endless protocols that they're not medically qualified. The fact is that they have more common sense than many medics. Not just non-medically qualified staff such as nurses and psychology practitioners, but also qualified physicians. That is, hardy perennials formerly known as doctors, before the concept of what a doctor is became so clearly, conveniently and confusingly muddied. Frankly, I'd rather work closely with a street-smart detention officer than a lot of NHS staff, even in a medical environment. This staff nurse was 6 shifts into her job. That's 6 shifts ever. Yesterday, she'd completed 5 sessions of mental health nursing, and this was her 6th, and she was prickly. If you're going to send somebody to a police station, of course, you send your least experienced member who doesn't know the patient or the specialty. Why wouldn't you? But I'm already becoming ungrateful. At least somebody was here to show that they had a duty of care. She didn't bring a list of medication with her, of course. Why would she? No, that's me being ungrateful again. Naughty me. I point this out because I involve patients in my decision-making with a policy of total openness. I am, with a few exceptions, more than happy to have a patient in the room whose healthcare might be directly affected by the decisions made. We owe them that at the very least, should they wish it. I could already sense the absence of humility. She wasn't going to be much help. She didn't have much time for me and didn't appear to be massively professional. Frankly, she could have just have smiled and made sure everybody had a cup of tea, and she would have been more use. But of course, nurses don't do that either anymore. It's not the 70s. Neither did she appear to be willing to learn. After all, what could this experience possibly teach her? What could I possibly teach her? A doctor with 25 years of experience and currently trying to help the police deal with a psychotic patient that they couldn't cope with in a psychiatric hospital. Normally, entry to police custody should be enough to attract some interest and excitement, but there was just cockiness on display. Sadly, one I've seen many times before over the years. It's just that it was particularly sad to see it passed down. She wore an argumentative defensiveness that would block good patient care everywhere it appeared, and a burgeoning arrogance. Frankly, she was a visitor to our unusual workplace, and wearing little humility comes over better than trying to be a bit of a know-it-all. Of course, nobody could ever tell her that in the NHS. If they had done, she would have made a complaint about bullying, or someone would have started crying. Someone would have been suspended, someone retrained. Nobody seems to be teaching professional bonhomie nowadays. It may be considered that they might have sent her on this away day just to get her sour face out of the building. That, in fact, is something I might have done myself. But then I reminded myself at least I would have sent award-winning paperwork to take with her to make her look good. I'm sure there was a time when junior nurses fluttered their eyelashes and smiled sweetly, but just at that moment, I couldn't remember whether that was a Carry-On film I'd seen or a false memory I'd planted in myself to pay a nostalgic nod to my faded charms. So I began trying to work out why this detainee/stroke patient was in our custody suite, but I already knew it. Some staff nurse had panicked with a voluntary admission by calling 999, not sectioned after all then. The script would usually go something like, "We didn't know how to assess the danger and we had to be seen to act." A classic case of CYA. Cover your ass. Of course, risk assessment is the salient art of medicine. It's no less so than in the specialty of psychiatry as anywhere else. It was obvious within a few minutes that the person had an unclear diagnosis. After all, she'd only been at the unit a few days. At least, it was unclear to her, and the nurse couldn't shed much light. And of course, she hadn't brought the notes, or a letter, or a clue. So we have a patient and their nurse with no sign of a diagnosis between them. Nobody quite sure why she is a resident on their unit. Nobody sure what medication she was on, or why. Uncommon situation? Sadly, no. At a basic level, it's a daily occurrence, and not just in police custody. If, as I and other portfolio doctors might. You see patients in general practice or in accident emergency or in walk-in centres or in tribunals and have to do written assessments on them in other capacities. It's clear psychiatrists and psychologists don't share much of that running with the patient of what's going wrong, where we're at, and how we're going to make a bit of progress. There's certainly an army of psychiatrists writing their multi-page reports which throw some shapes around various arguable diagnostic constellations, frequently presenting their favourite label almost as an exercise in debate, while omitting to tell their patients of their conclusions. But here's the rub. If the patients don't know what's wrong, then they can't tell me. And if I don't know, I can't tell anybody in A&E. They can't tell anybody in a walk-in centre. I can't tell the police. The system fails. We will revisit the failures of mental health services again along the way. But back to the station. She isn't kicking or screaming or scratching or fighting or punching. We're all in the same room together, and I'm still scratching my head trying to paint a picture of the dynamic that might have created this unholy stinking mess. The 5-day-old nurse decided to offer a defence of her senior nurse. We have to be seen to be doing the correct thing. Right you are, I thought. I smiled at her. Good for you. You'll go far. Give that girl a lollipop. She was beginning to copy and regurgitate a rusty model of care. Of course we don't, I thought. We have to do the right thing. And we have to know it's the right thing because we know what we're doing. I didn't say it. There was no point. She might have started crying. I know the logic of what the senior nurse did, but she taught it to another generation, and that generation was sitting in the chair opposite, spewing it back at me. If you have a patient 24 hours a day in a mental health unit and you have a problem, why not call a doctor? Call a mental health physician, a specialist already available on site, someone who can deploy their particular skills. Don't just get her arrested and send her to police custody, a place she may never have visited and of which you have no understanding. Care. Before you cover your own arse, just bloody care. If you're training, of course, it's not entirely your fault. How do you know which habits are bad habits? How do you spot which ones you shouldn't copy? Don't go into nursing to become one of the system. You've got to be better. We all have. It may be too late for your seniors. Sorry for the delay, Natasha. Name changed. I realise I'm here to see you. My apologies, we had other fish to fry. There was a nurse to save. The patient eventually remembered a diagnosis that she'd been given years ago, and talking to her, frankly, it made more sense than anything else I was getting, or any conclusions that the hospital had come to in the last 72 hours of a supposed assessment period. I understand protocol, but we're not dealing with protocols. In medicine, and in a paramedical specialty such as nursing, we're dealing with human beings, specifically this one, Natasha. Name changed. Care first. Cover your ass later. Please. Excuse the repetition. See you tomorrow.